Hello, I am Dr. Leong, a chest physician. This is an extract of a video recording from a webinar titled The Management of Cough and Phlegm. This video will explain how a cough is produced by our body in response to inhaled irritants, viruses, or bacteria. It also teaches us how to describe the problem of cough and phlegm to our doctors, so that our doctors will have a better insight into our medical problems. Thank you.
Now, cough can be acute, subacute, or chronic. Meaning to say, acute means within 3 weeks. All right, subacute 3 to 8 weeks. And today we are concentrating only on chronic cough, which is more than 8 weeks. So up to 3 weeks for acute, 2 to 8 weeks for subacute, and chronic more than 8 weeks or 2 months. So cough is actually a good thing. It is actually a good thing because it protects your lungs from all the bacteria, viruses that land into our airways, dust, the noxious chemicals, etc. Because by coughing, we expel the dirt from our lungs. All right. So it is a good thing to have cough. But of course, if it's too much or too troubling or too disturbing, then of course it creates a problem for us. Cough can be productive or non-productive. Productive means there is an abnormal amount of mucus, which abnormal means you can call it phlegm or sputum. Mucus can be considered to be normal, but if it is abnormal, we usually call it phlegm or sputum. Non-productive cough also occurs, and it is known as the dry cough. It means one's cough, but there's nothing coming out. It's a dry cough. So certain illnesses are associated with dry cough. So cough can be caused by infection, virus or bacteria, choking. Sometimes when we eat too fast, sometimes a little bit of the liquid or the food gets into our larynx, our voice box. Cough. We try to expel the particle that has gone in there. Smoke, as you know, air pollution, gastroesophageal reflux disease. It is also known as GERD. This is because of the gastric reflux up the esophagus, which should not happen normally, because when we eat, the flow of food will be in one direction towards the large intestine. So if there is a dysfunction of the gastroesophageal junction, a functional door, then food or liquid or gastric juice may actually regurgitate into the esophagus, causing cough. Posterior nasal drip, something to do with the nose problem or sinus problem. Heart failure can also cause cough because there's fluid in the lungs. ACE inhibitors, drugs used to treat hypertension, can also cause cough. This kind of cough due to medication can be very troublesome. So unless one discovers that it is due to the medicine, one has to remove the medicine, and then only the cough will subside. Otherwise, it won't subside. Many lung diseases cause cough, like asthma, chronic bronchitis, lung tumor, interstitial lung disease, etc. Cough mechanism, all right? So what happens during coughing? So the first thing is that we think it's a reflex, so we actually don't think about it. So initially there will be a deep breath, then the chest will compress the air inside the lung against a closed glottis. The glottis is around the region of the voice box. It's a closed glottis, so when the air is under pressure but cannot come out, it builds up. All right, and then suddenly, by reflex action, this glottis opens up, so the air under pressure will just be expelled out very powerfully, and that is your cough. So when one coughs, the particles can actually fly very far. That's why you have to wear a mask, so you can actually fly several feet ahead of you, ahead of us. So what happens in the cough reflex? There are receptors in the nose, there are receptors in the pharynx, the diaphragm, even the ear. They can cause cough, I'm sure some of us, even like me, when I clean my ear canal, sometimes I will cough. So it's also present in the trachea and the bronchi, the eating tube, the esophagus, and the pleura, the lining of the lungs. So these receptors at these places will send messages to the cough center, which is at the hindbrain, which is the medullary cough center. And from there, a reflex, usually motor, will go to the muscles of respiration. That means to build up your muscles, the pressure. The diaphragm, when it contracts, builds up the air. And also the glottis, when it opens up, then what do you call it? The cough will be produced. Efferent nerves, there are many types located at all the places that we have mentioned. They can be mechanoreceptors, stretch receptors, known as RAR, rapidly adapting airway receptors, SAR, slowly adapting airway receptors, and also chemosensors, C fibers, A delta fibers. All these are in the respiratory epithelium, the airway epithelium, all right? And they sense chemicals. All these impulses are sent by these nerves, like the trigeminal nerve, the glossopharyngeal nerve, and the vagus nerve. And where does it land? The messages will land at the hindbrain, the medulla oblongata, the hindbrain, and also part of it in the pons. And then all the messages will be centralized into the nucleus tractus solitarius, where the messages are sent then to the intercostal nerves, where it supplies the muscles of breathing in the chest wall, and also the phrenic nerve supplying the muscles of the diaphragm. Okay, so these motor nerves will create the kind of air pressure that is required to expel the foreign particles from our airways. Mucus is taken to be normal because our body produces mucus, all right? So this mucus is protective, and mainly 95% of it is water. It of course contains mucin, glycoprotein, immunoglobulins like IgA, lipids, and DNA, all right? So they are mainly produced by the submucous glands and the globate cells. So this mucus is what we have, all right? We produce about 15 mils per day of mucus, but we hardly notice it because they will be swallowed, all right? So this thin film of mucus, we usually, as it comes up from the airway up, we will usually swallow it. We won't be able to recognize it actually. So this is the airway epithelium. As you can see, is some mucus gland producing the mucus, airway lining. They are ciliated cells, all right? So there's this fine cilia here. These are the columnar epithelial cells. And this cilia moves, right? Usually in one direction, unless they are dysfunctional. And they will propel this layer of mucus up the airways and to be swallowed as normally because it's very little, all right? So some mucus glands are present in the upper airways, but not present in the lower airways. So this is a blown up picture, an electron microscope photograph of columnar epithelial cell. This is the airway lining, all right? And this is the cilia. So this cilia will beat rhythmically in one direction to propel the mucus up the airways to be swallowed, all right? And the cilia beats 15 cycles every second, propels the mucus 10 millimeter every minute. So it's a very slow process, but it does happen. Now, when we talk of phlegm, usually we mean it is abnormal. It can be colored. So when we talk, when we come to see a doctor, the doctor will usually ask the characteristics of the phlegm, the color. Only the mucus, if it is clear, it is good. When it is yellow or green, it usually means infection, all right? It could be brown or gray, even black sometimes, black particles, especially for those who smokers, the dirt from the cigarette smoke. And when it's red, it means blood, all right? So we also want to know the amount of mucus or phlegm, whether it's excessive, more than usual, or people with bronchiectasis or chronic bronchitis, when it's more than the usual they produce, that will be abnormal. Because patients with lung diseases like bronchiectasis or chronic bronchitis, every day they will have more phlegm than normal. They will spit it out. So when there is an infection, there will be more than usual mucus that they are producing. So this more than usual, they will usually tell the doctor. And that's when we take note of it. Either we need to prescribe antibiotics or we need to do some chest physiotherapy, right? We also wish to note the viscosity of the sputum or phlegm, whether it's sticky, easy to come out or not, because then will give us therapeutic options, whether to make the phlegm or sputum thinner so that it can easily come out. So, or whether it's fluid, all right, more liquid. And the time of the day, is it at night, whole day, or whatever? It will give us an indication. Like asthmatic cough, the phlegm usually come at night, all right? Lying down position. Some patients will tell us that, in a particular lie down position, there will be more phlegm coming out. And that is very important because we know then that position will be actually very good for the person to drain out the excessive mucus or phlegm. All right. Causes of persistent cough, we will only mention 3. There are many more. So chronic bronchitis is pretty common, especially for smokers or ex-smokers. Infection like pulmonary tuberculosis and bronchiectasis.